on behalf of we on behalf of DGOG oncology classes, we're discussing about intracavity plus interstitial brachytherapy in carcinoma cervix. We all know, all gynecologists or whoever practices, that today this intracavity plus interstitial brachytherapy has come in a big way in treatment of cancer cervix in aim of curing the patient. So it's a concept that we need to discuss and revise again over time. And we thought it will be nice if we can make an interactive class on this. So our DNP students, Dr. Jyotishna and Dr. Richa will be presenting from our from the behalf of DGOG to this DGOG forum on behalf of our hospital. And Dr. Jyotishna is second year DNP, and she's a very bright, intelligent student. And we have also Dr. Richa with us. She will be presenting the case. So we are ready for the presentation. As and when the administrator thinks, we will pitch in for presenting.
So I think we can start the presentation, and we can start Dr. Jyotsna's session. Yes.
Okay, so she will be starting. So let us start now. Please.
Good evening, everyone. Very good evening to my colleagues and my respected seniors. So today I'm gonna present on the topic of intracavitary and interstitial brachytherapy in carcinoma cervix on the behalf of a hospital, Medanta. So in this discussion, we will discuss introduction to brachytherapy, followed by then we'll see the brachytherapy course and systems. Then we'll have a brief look on point A-based brachytherapy in CA cervix. And then we'll see the limitations of point A brachytherapy and how did the image-guided brachytherapy evolve. Then we'll see a little about image-guided adaptive brachytherapy, which was given by Jack Extra Group. And then we'll discuss why intracavitary and interstitial brachytherapy came into picture. Then we'll see a little about intracavitary and interstitial brachytherapy applicators, and finally the clinical outcomes of the brachytherapy. So the term brachytherapy was first proposed by Forsell in 1931. It defined brachytherapy as a short distance treatment of malignant disease with radiation emanating from small sized encapsulated radioactive sources. The sources were directly placed into the tumor volume or near the tumor volume. So depending upon the position of the sources, brachytherapy was divided into this classification. So if the sources were placed into a body cavity, it was called intracavitary brachytherapy. And if the sources were implanted into the tumor volume, it was called interstitial brachytherapy. The surface plaque brachytherapy composed of sources loaded into a plaque, and then this plaque was brought near the contact with the skin surface. And if the sources are loaded into a lumen of the body, it is called intraluminal brachytherapy. Similarly, if the sources are brought surgically into or near the tumor volume, it was called intraoperative brachytherapy. So, according to the dose rate, the low dose rate brachytherapy was defined as 0.4 to 2 gray per hour. And if the dose rate was 2 to 12, brachytherapy compared to external radiotherapy. So if we try to achieve the required dose at the tumor tissue with EBRT alone, then it can increase the toxicity to the surrounding tissues. So brachytherapy, it provides us a better conformal therapy to the irregular tumor. Also, it avoids the geographical miss in the tumor. The other advantage is there is a sharp dose fall-off outside the target volume, and also the center of the tumor, which can be hypoxic or radio-resistant, it receives much higher dose, which cannot be achieved by EBRT. As we can see here, so this is the section showing CA cervix, which is going into the medial parametrium and the upper vagina. And we can easily achieve the dose by using the intracavitary brachytherapy, and the pear-shaped form is formed. Also, when we give the boost by brachytherapy, we can see there is rapid sharp fall of dose, and by the time we are reaching the pelvic wall region, the dose is much less, as we go far away from the tumor, the dose keeps on exponentially decreasing. Also, within the tumor, we can achieve higher dose up to 200 and 300%. So now we'll discuss about the brachytherapy course and the systems. So in earlier era, plain X-ray was used initially and 2D planning was done. And it was considered international standard until 2002. Numerous research articles have been published till then, and ICRO 38 it gave us the 60 gray volume dose. With the advent of the newer imaging techniques, then came the CT, and from 2002 to 2011, more and more centers started using CT-based planning. Various studies were done on this, and various clinical results were available from 2000, and it is ongoing till date. And Astro American Brachytherapy Society and Indian Brachytherapy Society guidelines have helped in this and have gave guidelines for the CT-based planning. With more advanced imaging techniques like MRI, which started around 2000, multiple reports were published by 2010 on MRI-based planning. And the Jacastro group gave the 4 guidelines for the MRI-based planning. And ICRO also adapted the Jacastro group guidelines for prescribing the dose for the MRI-based planning. So these are the initial intracavitary brachytherapy techniques. How did it evolve? So first came the Paris system. It had rubber tandem with 33.3 milligram radium, and it had co-colpostats, which had 30.3 milligram radium in each of the colpostats. The dose prescribed was in milligram radium per hours. It was designed to deliver a dose of 70 to 80 milligram hours over a period of 5 days. Then came the classical Stockholm system. It composed of an intrauterine applicator with flat box, which was perpendicular to the intrauterine applicator. But again, these were not fixed, so there was no fixed geometry. Here, 4,500 milligram radium was contributed by the vaginal box, and the dose rate was higher than the Paris system. It had a dose rate of 110 Roentgen per hour. It was given in 2-3 fractions. Now we'll discuss about the point-based brachytherapy in cervix cancer, which was given by the historical Manchester system. It composed of intrauterine tube, a flange, the 2 vaginal ovoids, which were separated by the spacer. And we could use different size of uterine tubes and ovoids. So it was basically the Manchester system, which gave us was the definition of point A, which said that point A was defined as 2 centimeter lateral to the center of the uterine canal and 2 centimeter above the superior mucosa of the fornix. So the historical Manchester system gave us point A based on the anatomy of the uterus. Then came ICRO 38, that therapy there is steep dose gradient in the vicinity of the radioactive sources. Selection of a reference point for reporting in the vicinity of the source, it raised difficulties. So ICRO 38 proposed that instead of reporting at a point, the reference volume should be used. And it said that the dimension of the volume in the corresponding isodose should be reported as a reference volume, and it was recommended as 60 gray volume. And ICRO 38 gave us the frontal pear-shaped isodose surface, which was used to extend the dose laterally. And in sagittal section, it was seen as banana-shaped distribution, which helped us to spare the rectum and bladder in anterior-posterior direction. Then came the difficulty that they found to choose the point A was the major difficulty was to choose a point. And they chose the point A on this basis. They said that it is anatomical comparable from patient to patient, and there must be one point at which the dose is not highly sensitive to small clinical or unimportant alterations in the source. So point A and B were defined. So they defined point A as 2 centimeter lateral from the central tandem and 2 centimeter above the ovoids. And similarly, point B was defined as 3 centimeter lateral to the point A. Then ICRO 38 also suggested bladder point to make the bladder visible. The radiopaque dye was used in the Follis catheter. So it said that in AP and in lateral X-rays, they marked the point at the center of the balloon first, and then they drew a line anterior-posteriorly through the center of the balloon at the posterior surface of the bladder. and the dose was prescribed at the bladder point to see the toxicity. Similarly, for rectal point, posterior vaginal wall was made visualized by using the radio wave gauge for the vaginal packing. And in anterior, posterior, and lateral, they marked the point. They marked the midpoint of the avoid sources and drew a line. Then they went 5 millimeters behind the posterior vaginal wall, located on the line drawn from the middle of the voids to mark the rectal point. So these are the applicators for intracavitative brachytherapy, the model applicators. There are mainly two types of intracavitative applicators. So first one is tandem and void type intracavitative brachytherapy applicator. So it composed of a uterine tube, central tandem, and two colpostats. It could be placed at, there can be various angles of central tandem and various sizes of the colpostats according to the geometry of the patient. And it was a semi-fixed applicator. And it was also, if we use titanium alloy, we could use it for MRI-based planning. And it provided the adequate doses to uterus, cervix, and upper vagina and the medial parametrium. And standard pear-shaped dose distribution was achieved by the tandem and avoid applicator. Then second type of intracavitative brachytherapy for applicator, we have tandem and ring applicator. It composes of a uterine tube and a ring as a vaginal source carrier. It again had a fixed geometry, and for MRI compatible titanium applicator could be used. It gave a little similar dose distribution as those of tandem avoid applicator, but the advantage it gave was it gave additional degree of freedom to load the vaginal sources over the avoids. So now we are going to discuss what were the limitations of point A brachytherapy and why we came over to the image-guided brachytherapy in cancer cervix. There's no doubt point A had inherent criticism, like point A was not a true anatomical point and it was not reproducible in all the fractions. Also, point A did not represent the true tumor volume because it was just based on the geometry of the applicator. And there were confusions, many confusions, and the point A definitions kept changing. So, but it's not due to this inherent criticism that we have adapted the image-guided brachytherapy. Rather, we have attained new advancements in imaging techniques, and we can give now better planning. So, image-guided brachytherapy helps us in many ways. So, we have shifted from point A to image-guided brachytherapy. Like now, we are available. We have volumetric imaging at both the diagnosis and the initial of the brachytherapy. Also, we have compatible applicators now. And image-guided brachytherapy helps us to understand the better contouring of the target volumes. Along with it, it helps us better optimizing the treatment plans and sparing the OARs. And with the advent of intracavitary and interstitial techniques, it definitely mandates the volumetric imaging and volume delineations. And the clinical results have shown that we can achieve more local control and less toxicities with image-guided brachytherapy as compared to when we prescribe at point A. So what's the relation between point A and HRCTV? Basically, point A absorbed dose, it did not predict the target absorbed dose in individual patients. Though in patients with balanced disease stage distribution, it can provide a reasonable estimate of the average CTV high risk. Like we can see in this graph, the y-axis, it represented dose received by 90% of the CTV high risk volume to the point, dose prescribed at point A. So cc, the ratio is more than equal to 1, which means that still we are achieving the prescribed dose at CTV high risk if we prescribe at point E. But for the tumors which have big volume at the start of the brachytherapy, like which have volume more than 30 cc, this ratio comes to be less than 1, which means if we are prescribing at point A in these cases, then we are actually under prescribing the dose to the CTV high risk volume. So it was better to proceed from the average dose prescribed at point A to the average dose prescribed to the CTV high risk volume. So ectorectal point doses, it was not a good predictor of dose received by 2 cc in individual patients. Though ectorectal point had good clinical correlation. But when we talk about ectobladder dose, it was almost 20% smaller than the bladder dose received by 2 cc of the bladder, with standard deviation of 32%. While the bladder reference point, it actually had no clinical correlation proved. So now we are going to discuss the Jacastro concept of image-guided adaptive brachytherapy. So ICRU 89, it gave the recommendations for the MRI-based planning, and it took the concept of Jacastro, which published 4 papers regarding the tumor contouring, the target volume delineation, and the planning of cervical cancer brachytherapy based on MRI images. So though ICRU 89 is a large topic, but yeah, there are 2 important chapters that we must read as radiation oncologists, especially the tumor and target volumes adaptive radiotherapy and the summary of the recommendations, which help us understand and better delineate the MRI-based image-guided adaptive brachytherapy. And also the Appendix A, which showed the comprehensive clinical examples, various clinical cases and technical scenarios. So we must know what's the difference between the image-guided brachytherapy and what is image-guided adaptive brachytherapy. So image-guided brachytherapy was 3D brachytherapy, because in image-guided brachytherapy we just use the CT scan or the MRI imaging at the initial of the diagnosis of the tumor, like before EBRT. So the 3D contouring could be done. But what additional adaptive brachytherapy gives is that it gives the time, which means that from the start of the EBRT to the start of the brachytherapy, that is to the end of the EBRT, how much disease has reduced. Like we can see in this graph, this volume, y-axis shows the volume. The initial, the white dot is, this is the volume prior to the therapy, that is at the start of the EBRT. Then at the first session of brachytherapy, the tumor volume has received. So in image-guided adaptive brachytherapy, we are giving the CTV prescription and all the dose prescription according to the residual volume of the GTV, not the initial volume. So this time picture has come into this picture and it has become 4D brachytherapy, that is image-guided adaptive brachytherapy. So it has improved the efficacy to toxicity ratio by exploiting the tumor volume regression. Like this image shows that it was the initial tumor extension at the time of diagnosis. It is given by GTV initial volume. So depending upon what are the patterns of the GTV response, depending upon whether it was a stable disease or there was a partial remission or there was a complete remission, different CTV volumes were given. So they were not according to the GTV initial volume, they were according to the GTV residual volume and how much pathological tissue is left. So this was actually called the adaptive brachytherapy. So again, this image again shows that high risk divided the area into the high risk CTV, intermediate risk CTV, and low risk CTV. So the high risk CTV represented the macroscopic tumor load, which is still present at the end at the start of the brachytherapy. That is the macroscopic GTV residual that we are seeing. It included whole of the cervix. Then CTV intermediate risk, it showed the significant microscopic disease. It depended upon the GTV at the initial at the start of the EBRT, and the low risk volume, which was radiated while the EBRT alone, it showed the potential microscopic tumor spread. So as we can see here, high risk CTV, it composed of GTV at the time of the brachytherapy. It included the whole of the cervix. And at that time, it was presumed that the tumor extended into the adjacent tissues, either on the clinical assessment or in the form of residual gray zones on MRI. It was included in the high risk CTV, and no safe margins was given to the CTV. Similarly, for intermediate risk CTV, it depended upon the GTV at the time of the diagnosis, that is before the start of EBT. And it in all the cases, it included the high risk CTV and it indicated the initial GTV. And the safety margins were given in case of the intermediate risk CTV. So, like we can see in this different staging, 1B, 2, 2B, and 3B. So the this upper image, it shows the initial GTV of the tumor. So like it's on the start of the EBRT. While this bigger picture, it shows the residual GTV. So for delineating the high risk CTV that is shown in red, they included the residual GTV along with whole of the cervix, and no margin was given to it. And the green, this green area, it shows the CTV intermediate risk. So it included the tumor extension at the initial of the GTV, along with it included all the parts of the high risk CTV, and it included the 1 centimeter margin, of course, pairing the bladder and the rectum. Similarly, in 3B stage, in this third diagram, we can see that the initial GTV was extending till the vagina. So but the residual tumor, it was just limited to the cervix. So when we contoured the intermediate risk CTV, when we contoured the high risk CTV, included the GTV residual, the whole of the cervix, and also the gray zones. That the black arrow is showing, we also included the gray zones in the region of previous GTV. But for the IRCTV contoured in green, it included the initial GTV, which is not included in the HRCTV. It included all of the initial GTV and the HRCTV cervix, plus along with the margin given. So also these are the OARs which are being shown in this planning. So brachytherapy related morbidity, they are usually linked to the small volumes receiving high absorbed doses. So these two pictures, they show the different positions of the vaginal part of the uterovaginal applicators, different positions of the uterus, and the reference volumes of OARs in two different patients. So they showed that for small OAR planning, instead of the point 0.1 to 2 cc volume, we should look the dose received by the 0.1 to 2 cc volume of the OARs, because they were sufficient to delineate one outer contour. And all the morbidities that we found later, telangiectasia, ulceration, necrosis, they all were dependent upon the dose received by the 0.1 or 2 cc of the volume of the rectum and the bladder, and mainly the 2 cc volume. So now we are going to discuss why intracavitary and interstitial brachytherapy came into picture. So in today's brachytherapy, we treat only after BC. So complex intracavitary and interstitial techniques they are not performed without imaging, and a better method than point A replacement can be discussed. So in this picture, as we can see that so the first picture shows this is basically the correlation between point A and CTV high risk. If we can give the dose to point A, or is it important to give the dose to the CTV high risk? So in first picture, we see when the tumor is limited to the cervix, then if whether we prescribe the dose at point A or CTV high risk, we are covering the tumor. But in the second picture, as we can see that the tumor is extending laterally into the almost the lateral parametrium. Like if we see in the right section, it is almost the maximum width of the point of the tumor from the central tendon is 4 centimeter. So if we prescribe the dose to point A, then we will underdose the tumor at the lateralmost point of the right-sided volume. Similarly, in left side, the tumor extension is around 2.5 centimeters from the central tendon. So if we keep prescribing the dose to point A, then we are definitely going to miss that part of the tumor, and it will get less dose. It will get less equilibrium, and we will not be able to achieve the what we are trying to achieve with the so the right the equilibrium will be around to 57 gray, which will be 47% of the prescribed dose. Similarly, to left, we can only achieve the equilibrium of 78 gray, like 80% of the prescribed dose. So what is the need of the image-based brachytherapy? So basically, intracavitary and interstitial brachytherapy it's not only the alternative for all the cases. If the tumor just extends a little more than what we planned by the intracavitary brachytherapy, image-guided brachytherapy can help, and we can formulate the dose. So also image-guided brachytherapy helps in checking the proper application and proper delineation of OARs. Up to around, if the tumor extends up to 2.5 centimeter, then we can modulate by using the image-guided brachytherapy. But in case the tumor is extending much more, then we have to go for intracavitary interstitial brachytherapy to give the adequate dose to the tumor. Like in first case, we can see that the residual disease is limited to the cervix. These are the indications for intracavitary brachytherapy. If the residual disease is limited to the cervix, or if the residual disease is at cervix and it's limited to the medial parametrium or the upper vagina, then we can take the case for intracavitary brachytherapy. But if the the residual disease at the end of the EBRT, it's extending into the lateral parametrium beyond the middle third, or if it is going to the middle or lower third of the vagina, then the whole of the tumor cannot be covered by the intracavitary brachytherapy. And so we go for the interstitial brachytherapy with the help of the needles. Then the needles can be placed according to the position of the tumor. Then, as we know, the standard treatment for cervical cancer is external beam radiotherapy along with concurrent chemotherapy. And then, depending upon the assessment at the end of the EBRT, if small disease is left, go for standard Okay, so am I audible now?
Yes, yes, you're
Okay. So we were talking about the image-guided brachytherapy. So at the end of the EBRT, let's say in the first picture, we get this big residual volume. And if we try to cover it with standard intracavitary brachytherapy, then it will be inadequate. Because we will be missing the target. We will not be prescribing all of the target, the adequate dose it requires. But in the lower down left picture, if we plan the same case with intracavitary plus interstitial brachytherapy, then we can adequately cover whole of the target volume. So image-guided brachytherapy, it's not only important for the big size tumor volume. It doesn't mean that intracavitary plus interstitial brachytherapy can only help if the tumor is big. It also helps in the small residual volumes. We'll see it how. So in the right upper picture, we see the tumor residual volume is small. If you try to plan it with intracavitary brachytherapy, no doubt the tumor is being covered, but we are giving extra dose to the bladder and the rectum. In this case, we can see they'll be giving the extra dose to the bladder. So basically, the patient end up coming with the bladder symptoms and other symptoms. But with the planning of intracavitary plus interstitial brachytherapy, if we plan the same small case with this, we can spare the dose to the rectum and the bladder. So this is the way that also if the patient, the tumor is distorted anatomy, it can be better planned with the intracavitary and interstitial brachytherapy with the sparing of the OARs. So the retro-embrace trial, it showed the image-guided brachytherapy combined with radiochemotherapy. It led to the excellent local control, pelvic control, and the overall survival, along with limited severe morbidity. It gave us the 3% actual control in different. It showed that image-guided brachytherapy can lead to better local control and pelvic control. So the retro-embrace also showed that the dose received by 90% of the CTV high risk, it showed that more dose can be achieved by using the intracavitary plus interstitial brachytherapy. Like in case of intracavitary plus interstitial brachytherapy, we can go up to 92 gray. While in case of intracavitary, we cannot escalate the dose much. We can only go up to like statistical. Also, it showed that if we compare intracavitary and intracavitary plus IS brachytherapy, and if we compare the probability of the local control in these two groups, if the residual tumor volume, that is high risk volume is more than 30 cc, then IC plus IS group showed better local control. It was significant as compared to the IC group alone. But if the tumor volume, the residual tumor volume is small, that is, it is less than 30 cc, then both the groups, the IC plus IS groups and the IS group alone, they had similar local control. There was no much benefit of IC plus IS group in lower CTB high risk volume, which had volume less than 30 cc. So this image shows for the small volumes, like if the tumor volume is less than 30 cc, and if we are giving the higher dose, then there is no higher local control in the higher local control in the case. We are just increasing the dose of the bladder and the rectum. So in this case, we can de-escalate the dose. Even then, the local control will be similar. It has just come down from 96% to 95%. So this is not significant. The local control will be significant, will be same if we de-escalate the dose in a small volume tumor. Similarly, if in higher risk volume, if we are not able to achieve the adequate if not able to achieve the adequate dose to D90 volume, then the local control is significantly lower. So we need to escalate the dose in the higher risk volume so that we can achieve a good local control. So for dose escalation and de-escalation, both the things are necessary: image-guided adaptive brachytherapy and the intracavitated plus interstitial brachytherapy. Also, for the organ at risk, it showed that if we are giving less than 80 gray to the bladder, then the side effects are less. And as soon as we give as soon as the 2 cc of the bladder gets more than 80 gray, then the side effects and the morbidity, it increases significantly from 15 to 30% or almost 40%. Similarly, in case of rectum, if the dose received by 2 cc of the rectum is less than 65 gray, the side effects are lesser. And as soon as the dose gets more than 65 gray to the 2 cc of the rectum, the risk of rectal bleeding, there is steep increase in the risk of rectal bleeding. The EMBRACE-1 trial, it aimed at to evaluate the local control and morbidity after the CTRT and the MRI-based image-guided brachytherapy. It included most of the 1B to 4A of the disease, and also the 4B restricted to the para-aortic lymph node metastases. So it showed that image-guided adaptive brachytherapy, it provided effective and stable long-term local control across most of the stages of locally advanced cervical cancer, and also it along with the limited severe morbidity in the rectum and the bladder. So now we are going to discuss about intracavitary plus interstitial brachytherapy applicators. So in MUPIT type, the standard IC loading is not possible. The CT and the needles within the cylinder, they are loaded more. So, but the intact uterus allows to do more loading in the CT. So the 200% dose is confined within the applicator or the uterine cavity. Because the MUPIT, it had the perineal template, and they are excellent in providing the desired dose distribution. And also it can cover almost all types of the cervical cancers, and it is time tested. But the disadvantages of MUPIT were that it was cumbersome, then also it was time taking to assemble. No doubtful, it was painful for the patient also. And there were chances of displacement as it is attached to the perineum. Also, it gave rise to the artifacts in the CT as needle of the CT. And in fact, these are the disadvantages for the perineal. And there were more chances of organ perforation due to the sharp steel needles. And there were more chances of bleeding also due to stale divergent needles. So we have come over to intracavitary and interstitial applicators. The first one is the tandem ring type applicator with interstitial needles, the Vienna applicator. And this MRI compatible tandem with ring with an array of holes inside the surface of the ring template, which can go up to the level of vaginal fornices to insert needles into the parametrium. So the needles, they improve the lateral dose throw-off by another 1.5 centimeter to treat the addition. I would better say 1.5 to 4 centimeter. And in tandem, a wide type applicator with interstitial needles, like the Utrecht applicator and the Geneva applicator, it had holes in the avoids to insert the needles into the parametrium to cover the to improve the coverage before application. And then these are the tandem ring based applicators, like they can be Serra's ring cap applicator, Venezia applicator, then Alice caps mounted on a split ring applicator, and Venezia applicator, and so on. So then we have tandem and ovoid applicators, like modified Rotterdam applicator, the Utrecht interstitial bracket CT and MR applicator, and the Geneva applicator. Then tandem and template based IC plus IS applicators. So this is the paper published in 2020, we had taken this picture from that paper, which also included the Maulo applicator, the Medanta anterior oblique lateral oblique applicator developed in Medanta, and it is considered as the tandem and template applicator. So these are various tandem and template type applicators. Also, there are some tandem-free hand needles, which the needles are placed free-handedly. But of course, these require experienced physicians for this. So a little about the Medanta anterior oblique and lateral oblique applicator. It has entry and exit points of 3 anterior oblique catheters in the direction of the intrauterine part of the central tandem. And there are oblique paths for 3 lateral oblique needles in the direction of the lateral parametrium on either side. Also, it has 2 channels for lateral straight needles and 1 anterior straight needle and 2 posterior straight needles. So it allows the coverage of distal parametrium up to 4.5 centimeter of the middle of the intercavitary tube at the level of point A and the upper third of the vagina. And the intercavitary tandem, it helps to straighten and stabilize the whole of the application. So these are the various modalities which we can use for cervical cancer planning. Of course, the clinical examination for the target volume delineation has always been the gold standard. Similarly, MRI is also gold standard for target volume delineation. But ORs, they cannot be delineated according to the clinical examination. But yeah, clinical examination, it has a great ease of access, and it is a must before going for the brachytherapy. And for MR guided, though it provides a gold standard for target volume, and the OR delineation is also very accurate. And treatment planning is definitely better in MR based brachytherapy as compared to CT guided, but it is less available. So MRI is not available in all the centers. So it is also it needs the experienced hands to go for MRI based brachytherapy. While CT guided, it needs supplementary information. We can fuse the images with MRI, but the CT in the OR delineation is accurate, and also it is easily available in most of the centers. So we can go for CT-based brachytherapy easily. The ultrasound, though the target volume delineation is comparable to MRI, but it is not practiced in India, and this area is still to be explored more. Then Indian Brachytherapy Society have also given the guidelines for the brachytherapy. It has given it says that the CT can be used for planning as an alternative to MRI because MRI is not available in all the centers. So CT for delineation of organ at risk and evaluation, it's a routine now. And tumor related target area is of current research because in MRI we can better delineate the tumor. And so what are the advantages of CT scan? The advantages of MRI based brachytherapy is that MRI is gold standard in delineation, and the clinical results are excellent in both tumor control and toxicity. But the disadvantages are that it is not available in most of the centers for brachytherapy, and it's also considered costly, and applicator reconstruction needs both expertise, and there should be MRI compatible applicators to go for it. And the benefits of image guided adaptive brachytherapy, especially the intercavitary plus interstitial techniques, they cannot be reached when they are needed the most. For CT, the advantages are it is commonly available in most of the areas of the developing country, and it is more pocket friendly, and it does not require that experience, and easy application can be done. And the disadvantage is that it is not gold standard for the target volume delineation, and results of MR guided image guided adaptive brachytherapy are yet to be replicated in the case of CT. So here we have compared the 2D planning brachytherapy with this motorbike, and 4D CT image guided brachytherapy. It's like Maruti Suzuki, and 4D guided MRI image guided brachytherapy. It's like the recent Audi cars. So for 2D, it is though cheap and cost effective, and it can be used for the treatment of the mass, and it is time tested, and there is unpredictable toxicity. And it's like there's the most experienced doctors we say that I just love my first bike. So also the 20 brachytherapy 2D planning has been the backbone of the brachytherapy. So when we come to the 4D CT image guided brachytherapy, it is affordable, it is cost effective, and more safe. So more safe than bike, of course, but it is little costly than bike on the initial investment, but it is better for the long term when we go for the bigger tumor. And it gives the less late toxicity as compared to the 2D brachytherapy. But yeah, there is no GPS in the car, so um, so in CT guided brachytherapy as compared to MRI based brachytherapy, it is little inferior. So in MRI guided brachytherapy in 4D planning, here we say that we can get the real time GPS approach, that like we can get the HRCTV dose volumes, and also it has back camera, so it symbolizes that it also has a better visibility to the OARs. But the problem is that it is costly and not everyone can afford it. So the mainly it is the CT image guided brachytherapy, which is more available and better for the brachytherapy. So these are the clinical results of intracavitary and interstitial brachytherapy in CS cervix, which was published in 2020 by Lee et al. And it comprised of many studies that have been done, and it shows the outcomes of the HRCTV size and how the tumor local control at 2 years, in case of local control, overall survival, and the progression-free survival have come. And they show the important outcomes of the intracavitary and interstitial brachytherapy. So, can we do away with brachytherapy in cancer cervix? Absolutely no. S. Gill, he found from 2004 to 2011 that though the brachytherapy use had decreased from 96 to 86% in these years, but the overall survival, the adjusted overall survival seen with brachytherapy was more than the survival seen with the photon brachytherapy, the SBRT or the IMRT. So it was the National Cancer Database Analysis of Radiation Therapy. So with the IMRT or the SBRT, it cannot replace the brachytherapy, and the overall survival was affected significantly. So if we see that from no brachytherapy to 2D brachytherapy alone, the overall survival, it increased by 12%. And if we compare the 4D brachytherapy as compared to no brachytherapy, there was a total improvement in overall survival of 25%. And similarly, even if we compare the SBRT, the 2D brachytherapy gave us better overall survival, the significant better overall survival than SBRT, let alone the 4D brachytherapy. So the take-home message is that for the cure of the cancer treatment, cancer cervix, the three things are of utmost importance: the overall treatment time, the high-risk CTV volume, and the dose equity D2. And with the newer advanced image-guided brachytherapy and the excellent techniques of intracavitary plus interstitial brachytherapy, we can definitely increase the dose equity to the tumor volume, and then we can better delineate the high risk CTV volume. And thus, this is how we have progressed in the brachytherapy, cancer cervix brachytherapy. And so at the last, I'll like to thank all my colleagues our HOD, Dr. Tejinder Kataria, and my moderator, Dr. Susovan Banerjee, and all of my colleagues and all the seniors, and also our respected physicist, Dr. Venkateshan. So for providing me this chance to present today's lecture, and also Dr. Soren. Thank you, ma'am. Thank you so much.
So, hello, I think I am audible. Hello.
Yes, sir, you're audible clearly.
Jyotsna, for this presentation, because we all understand it's very mammoth task to present this intercavitary interstitial brachytherapy within this short time, but then long lectures are boring and we do not intend to make it boring. So it has been done in a very crisp way, and I think she has covered almost all aspects of this intercavitary interstitial brachytherapy, especially because the topic was that only. Otherwise, it would have been a very big lecture. And now we can take some questions, or we can go for actually case presentation. Maybe we can take questions at the end of the case presentation. That may be better, I think, because the case presentation will take around 15 minutes to 20 minutes. So we should go for the case presentation. That is a single case we would like to discuss with our residents and colleagues. So if I summarize from everything, so intercavity interstitial brachytherapy is a versatile mode of delivering brachytherapy which keeps intact the original form of intercavity brachytherapy in cancer cervix. Intercavity brachytherapy in cancer cervix has a history of almost 100 years. Actually, it is the oldest form of treatment for cancer. So we will have to, but then how it can be improved further? It was simply improved further by adding few needles that can actually help in escalating the dose. It is like now, like you can say it's like IMRT in terms of brachytherapy. I am not going to confuse anyone, but it's like that. As in IMRT, you have multiple fields from multiple directions, and at the end you converge to one point, just raising the dose and just sparing the organs. So it is like that. If we can compare that in intercavity interstitial brachytherapy, each needles are like one beam, let me, or from one side. So you can understand this number of entry points of the radiation actually is helping us to escalate the dose to the primary and at the same time reducing the dose to the OR. But this type of technique is very simple, but then it should be adopted in most of the centers. So let us now present the case.
I think Dr. Richa is facing a little problem in sharing her screen. So Dr. Susovan Banerjee is helping her. So there is a little break, but we are trying to connect very soon.
In the meantime, we can discuss any questions. Dr. Richa is there, no? So can you help Dr. Richa to present the case? She is there actually, but she is not getting the screen sharing option. In the meantime, if somebody asks any question or wants to carry on the discussion, please go ahead.
So Dr. Richa has to unmute herself. She's muted.
Yeah, she's unmuted you.
I'm unmuted now, but
Yeah.
I do not get. But I'm
Fixing
not getting
options
the
पे जाओ.
screen sharing option.
Just check the right corner, bottom right corner. You'll get the share option.
Bottom right.
Dr. Richa, you can share your presentation with me. I'll put it. I'll share my screen.
No, we'll do it that way. वहाँ से ऐसे करके we'll put this in front.
हेलो इस कंप्यूटर को उसमें से कैमरा में दे देता हूं ठीक है नहीं शेयर नहीं किया आप मेल आईडी दीजिए टाइम पता नहीं मैं देखता हूं
मुझे किसी और तरह की दिखाई दे सही ये जो आपने भेजी है यही है क्या
हां भैया खोलो
यही है क्या
हां हां तो शुरू कर दो
तो फिर यही है तो फिर मैं अभी
भैया डाउनलोड करो उसको
मैंने इसको किया तो सही कर रही हूँ बस आधा मिनट दो मुझे
अरे क्या
Yes, sir, we can see the screen now.
We are ready with it, I think.
Yeah.
But no, that is not the only one. But it is a part of it actually.
Okay.
So, निकला क्या? ये पूरा नहीं यार. Have you? अच्छा, I have. It is not the right one. Anyway, you can actually put this camera on this phone as well.
तुम्हारी तरफ से क्या तुमने वहां से मिल के वो ऐसा मेरे लिए फिर वो पॉसिबल नहीं है मुझे भेज
କରିପାରିବନି ସେ ଦେଖିବ ଲାଷ୍ଟ ବେଳକୁ କରିପାରିବ ନେଇକି ଯିବ ସୁଚିତ କରିଛନ୍ତି ଆହୁରି ଏ ଭାଇ କହୁଥିଲି ସେଇଭଳିଆ କାଗଜ ପଳେଇଲାଣି କୁଆଡେ ତାକୁ ନାହିଁ ସେ କାଗଜ ଅନନ୍ୟାର ମୋର ଦେଖି ଦେଇଥିଲି ମୁଁ
कैमरा ऑन करके इसमें दिखा दो So, can we start?
Yes, sir.
ये आपका ही फोन है, मुझे इको हो रही
तो कैसे करूंगा मैं उसको? तो वो तो कुछ तो बात फोन से आवाज नहीं आ रही है ना।
है।
मेरे फोन की स्क्रीन क्यों शेयर कर दी? मेरी फोन की स्क्रीनिंग मत शेयर करो ना यार तुम अब।
ये चतुष्पा में Can you hear my voice?
Yes, yes. Yes, we can, please.
Okay,
Please
okay, thank you
proceed.
so much. Sorry for the inconvenience.
Perfectly all right.
Good evening, everyone. Respected seniors, my colleagues, and dear friends. I'm presenting a case capsule on this carcinoma of cervix. So my patient, a 72-year-old lady, para 3, live issue 3, all normal vaginal delivery. She attained menopause 20 years back, and there's no significant past history. She presented to us with the complaints of white discharge and pain in the lower abdomen and back for 8 weeks. There's no complaint of any post-menopausal bleeding. There's no history of fever or change in bowel bladder habits, no history of any chronic infection, no history of promiscuity in both partners. Her past menstrual cycles were regular. Coming on to examination, on general examination, ECOG performance status was 1, vitals were stable. There was no pallor, icterus, cyanosis, clubbing, or any lymphadenopathy. In normal examination of non-tender, there was no palpable organomegaly. Coming to local examination, external genitalia, skin, vulva, and urethra were normal. In per speculum examination, the entire cervix was replaced by an ulceroproliferative growth approximately 5 into 4 centimeters involving the upper third of vagina. On per vaginum examination,
There was a large ulcer-proliferative growth, 6 into 5 centimeters, involving the entire cervix, internal and external os, upper one-third of vagina. All the fornices were involved and it bleeded on touch. Bidigital per rectal examination was done. Rectal mucosa was free, but bilateral parametrium was involved, reaching up to the lateral pelvic wall. The cervical biopsy came out as well-differentiated squamous cell carcinoma. Cystoscopy and sigmoidoscopy were normal. There was no invasion of urinary bladder wall or rectal wall. This is the diagram showing the disease extent. It was in the cervical canal and uterus, 6 into 5 centimeters. The green part describes the extent in the upper third of vagina, and the blue one, as you can see in the second, image, describes the parametrial involvement, which goes up to the lateral pelvic wall. So the red is the uterus, red is the cervix, green is the vagina, and the blue is the parametrium extent. The CE MRI was done. There was a large lesion, 60 into 30 mm, with central necrosis involving the cervix, lower uterine corpus, upper vagina, and parametrial extension laterally on either side, reaching up to the lateral pelvic side wall. There was no pelvic lymph nodes noted. So the impression is carcinoma cervix, FIGO stage 3B. We planned for concurrent chemoradiation, 45 grain, 25 fraction, followed by brachytherapy. Patient received radical RT, 45 grain for 25 fraction, with 4 cycles of concurrent chemo, carboplatin, which was completed in 5 weeks. While on chemoradiation, there was grade 1 GI toxicity and grade 2 geotoxicity, did not warrant any treatment breaks. Post EBRT, when the examination was done, you can see the residual disease is still there, but the disease has decreased in size. It was approximately 2 into 3 centimeters. All the fornices were involved, and upper vaginal wall was also involved. In birectal PR examination, rectal mucosa was free, and both parametrium were thickened, right more than left, but not reaching up to the lateral pelvic wall. The reassessment MRI pelvis was done, which shows a significant reduction in the size, now 2.6 into 2.5 centimeters. The mass involves the lower uterine corpus and upper vagina. Small parametrial extensions were there on both sides. The mid and distal vagina appeared normal. As you can see in this comparative MRI, pre and post treatment, the disease has reduced significantly. After this, in view of the residual disease, we planned her for intracavitary and interstitial brachytherapy to a total dose of 26 grain. We had a video for this, but due to the technical problems, we removed the video. So the patient was positioned in lithotomy, and after administered anesthesia was done. So the findings were confirmed: 2 into 3 centimeter induration over the posterior cervical wall. The os was identified and it was deviated towards left. All the fornices were involved. Upper vagina was involved. Both parametrium were involved. Right side more than left, but not reaching up to the lateral pelvic wall. After cleaning and draping the perineum, 18 gauge Foley was inserted with the bulb inflated with contrast solution. The uterus was sounded and serially dilated. 15-degree central tandem was placed, and the Aulo applicator was placed with 17 interstitial needles. Vaginal packing was done with wet gauze. Rectal marker was placed, and the applicator was secured using a T bandage. The NCCT imaging was done, and it was used for planning. For target volume delineation, as we must know, MRI is the gold standard, but there are JAK-ISRO guidelines for GTV, HRCTV, and IRCTV, which should be followed. Target volumes are made accounting for the clinical examination and MR findings before EBRT and at the time of brachytherapy. Recently, CT-based target volume definitions are also available. Coming to target volume delineation, CT is the primary imaging during brachytherapy. The findings from pre-EBRT and pre-brachytherapy MRs are considered. Trust-wide findings are also very valuable. Near maximum distance should be kept in mind. The GTV cannot be drawn, so many centers draw only the CTV that represents the high-risk CTV. After this, the planning applicator reconstruction is done by our medical physicists. Planning and dose prescription. The standard ICBT dosing, the normalization is done to point A. Source position in the needle and tubes should be manually activated in relation to the target, that is the HRCTV. Dwell time in the needles is in the range of 10 to 20%. The plan evaluation and documentation of various dose volume histogram parameters are done. Graphical optimization is in local mode, and also there is manual optimization. As you can see, I'm showing two plans, IC and IC plus IS. So in the first one, as you can see, in the intracavitary plan, the residual disease is being the residual disease is not getting the proper dose, as the volume is not covering up to the. Okay, and in the second diagram, as you can see, in the intercavitary and interstitial planning, there is customization. We can customize the dose distribution and throw more dose laterally, that is more than 4 centimeters. So the IC and with the IC and IS application, it is possible to cover the lateral parametrial disease, and also the OAR constraints are achieved because the dose distribution is more conformal, and the 100% isodose line is not now going into the bladder and rectum. Coming on to the removal of the applicator, it is done under sedation mostly. IV access is secured. We remove the metallic oblique needle separately. We watch for bleeding. We avoid using any anticoagulants to prevent DVT. We encourage the patient to mobilize the leg, and manual massage is also done. It is done under adequate analgesia. Patient is reassured and we watch carefully after removal that the number of needles are accounted for, as well as the tips of catheter, as they must not be left inside. This is the planning done for our patient. The EQD2 we achieved was the HRCTV volume was around 60 cc. The bladder and rectum dose were well within the constraints, and the EQD.
So the case is already being presented, but the last moment there was some problem, and the only few slides are left now. Dr. Richard has to read it actually. So HRCTV volume was about 60 cc, and the bladder and rectum dose 2 cc rectal dose was around 65 gray, and the sigmoid was 60 gray, and the bladder received around 77 gray of EQD2 dose. And the patient is now in follow-up for last was follow-up for last 1.5 years, and in 1 year and 3 year PET CT MRI that has been successfully done, the patient has no disease in local or distant, and the patient, she also doesn't have any toxicity, although toxicity is expected with such a high volume of HRCTV. But we were able to manage the patient here, and next this is all about it. And about removal, we must read for IC plus IS class of applicator, we generally remove the applicator in total one together, but just the slide we could not show, but I will advise, or we will rather advise, for the patient who are having steel needles, divergent especially, where there are a number of needles actually, and there are a fibroid in the patient's number of needles, the needle should be better removed separately, because it can cause tear of the vagina from the divergent needles, or it can cause actually uterine prolapse. So that is a very important thing. The applicator should always not be removed together. It should be removed only there are very fewer needles, or the patients, especially if the patient is frail, there is a large chance of uterine prolapse. And that is all about it. Now, any questions or comments, suggestions? We have finished from our part. We want our colleagues and our peers from other parts, especially DNB students, to interact, to ask questions, to encourage us. so that we can understand if our presentation was fine, if they have any question, queries on interstitial brachytherapy like that. So interstitial intercavity brachytherapy is such a big topic, it can't be covered in class, but I think we have fairly done justice to it. So any questions or comments from Vinita madam or?
Hello.
Yes.
Hi,
Yes, madam.
Susovan.
Good afternoon. Yes, madam.
Yeah. Good afternoon. The presentation was good, excepting from some technical glitch and all. I would suggest that the topic should be. This is overall. I think it's overall topic. No? About brachytherapy, you covered almost everything in one topic. So for students' point of view, as it is a student-oriented program, and audience is mainly students, postgraduate students. So you covered it bit by bit, first 2D and then how to cover to point base. Then you go to this MR base and all. You are too fast going, no?
Yes, madam. It was really fast because
jumping. That's a little bit. I think little bit difficult to understand for the students.
okay, madam.
So for teaching purpose, no, you prepare accordingly. Little bit slowly move, no, from 2D to 3D and MR base. I think that's all. Overall,
Yes,
good
madam.
presentation.
Thank you, madam. Thank you.
Yeah, welcome.
So if there is a question, you can answer, or otherwise. So RT fibrosis versus residual, whenever we see the patient at the first time, the gross volume of the disease is very important. So if there is a nodular filling in the region of the gross disease, then we should take it as a residual disease only at the time of brachytherapy, not as a fibrosis, because fibrosis post EBRT, we plan brachytherapy, and fibrosis is not it is not natural to happen fibrosis within 2 weeks. So it's about the extent of the disease at presentation before EBRT that defines the HRCTB nodularity, filling of the parametrium, everything. So that is why 2 MRI are actually required for ideal delineation in a MR environment. Any other question? Actually, this was regarding the question. Question was asked: how do we differentiate between RT fibrosis and residual disease? So that was the answer. The pre-EBRT volume will define if it is a fibrosis or if it is a disease-related nodularity. Question is chat box में. Any other questions? No. Cut gaya kya? So if there is no question, we can leave. Thank you.
So I would like to thank on behalf of Oncology Forum for compiling such a wonderful academic, interactive session. And I'm sure there were a lot of efforts to, prepare such extensive and such educative slides. So I would like to thank Dr. Susovan Banerjee, Dr. Jyotishna, Dr. Richa, and all other participants. Thank you, attendees, for,
There is a question, Dr. Nidhi, and maybe somebody has asked, so I will just you are giving thanks, but I will just answer it also. What will you do if the os is obliterated, right? If the os is obliterated, it's not is, I think. So if the os is obliterated, look, to do an interstitial intercavity type of brachytherapy, the most important thing is to find the os. If the os is found and the central tandem can be inserted, then half of the job is done. Whatever energy we put in putting the needles, we always remember that putting the central tandem is the best thing that can happen for the patient. So even if you do not get the os, you should always call your seniors in the department, because, or even your juniors in the department, because you never know who is going to find the os. So in case somebody is not finding to find the os, first you ask the help of a colleague, senior, junior, whatever, who is confident of finding. And if you have a ultrasonography machine in the department, that will actually help you to find the os. At times, the real time, you can insert the tandem by seeing the cervical canal. But in case, even after so much headache, you cannot put the os, then you will have to go for interstitial, plain interstitial access. Okay, thank you, Dr. Nidhi. Thank you. Any other questions?
you.
Okay,
Yeah,
thank
so
you.
thank you, sir. Thank you then. And
Thank you, Dr. Nidhi. Thank you, and good night to all of you.
good
Thank you.
night to everybody. Thank you. Okay, bye-bye.